Well, hello everyone. Welcome to just a disclaimer here. I want everybody to be aware that the contents of this presentation do not represent the views, opinions, or policies of the United States government, the Air Force, the Army, the Navy, the Department of Defense, or any other federal agency. These opinions are presented solely based on my thoughts and assessment of the literature and should not be construed as official medical advice. They are meant to be informative, thought-provoking, and are intended to accurately reflect publicly available information found elsewhere. Please consult directly with your physician before making any personal medical decisions based on any content in this presentation. So the outline today, we're going to talk, as we said at the beginning, about COVID-19 vaccination. So we'll do a brief review of the available vaccines. Then we'll talk about who's eligible for vaccination, discuss where you might go to get vaccinated, and then consider the question of, is vaccination right for me? After we talk about COVID-19 vaccination, we'll touch on a completely different topic, which is diagnosing cancer recurrence. We'll talk about remission and surveillance, symptoms of recurrence, asymptomatic versus symptomatic recurrences, and preventing recurrence. So we'll jump right in here to COVID-19 and the available vaccines. So as I'm sure everyone is all too familiar, currently there are only 2 vaccines on the market that are being given, and these are being given under FDA emergency use approval. So they have not been fully approved by the FDA. There are, as I'm sure you've heard, several vaccines that are going through the other phase 3 trials and also seeking FDA emergency use authorization, and may be joining these 2 vaccines for availability. But currently we have the Pfizer BioNTech vaccine, and then we have the Moderna vaccine. So both of these vaccines are based on a RNA type vaccine to this viral spike fusion protein. I think the way they're produced and the target is similar, but slightly different. So the emergency use authorization really came after some large phase 3 trial data was presented. And that data is shown, here in this second bullet point on both of these vaccines. You can see that the Pfizer vaccine reported a 95% effectiveness, and that was in patients age 16 or older, and they had 37,706 patients in this study. The Moderna vaccine was 94% effective. They had ages 18 and older, and they had slightly fewer clinical trial participants, 30,400. Just as kind of a breakdown of the vaccines, or the group that was studied, the way the Pfizer study broke it down was age greater than 55 accounted for 42% of the study group. Age 16 to 55 was 58% of the study group. And then in the fine print, or the supplementary data, you can see that 20% of the study group had a significant comorbidity. And you really have to kind of look at the study data to figure out what those significant comorbidities were. But suffice it to say that after reviewing those, there were actually a handful of people in the Pfizer vaccine study that had cancer. But that included leukemia, lymphoma. There were really only 1 or 2 people that had what we call metastatic solid tumors, which is kind of what a GYN malignancy would be. And the numbers were so small that it really accounts for what we would consider about 0% of the total study population. In the Moderna study, they broke it up into age greater than 65 with or without risk factors. and about 25% of that group in that study was 65 or older with risk factors. And then, I'm sorry, I misspoke. So age greater than 65 with or without risk factors, they didn't, if you were over 65, they didn't necessarily parse it out into what those risk factors were, but that was 25% of the study group. And then age 18 to 65 with risk factors, that was about 17% of the study group. And then everybody else was under age 65 with no risk factors. And of note, they did include HIV positive patients, and it only accounted for 0.6% of the whole entire study group. So doses, 2 doses 28 days apart for the Moderna vaccine, 2 doses 21 days apart for the Pfizer vaccine. The primary endpoint for these studies was very similar. The Pfizer was prevention of symptomatic COVID-19 infection at least 7 days after vaccination, and they also had another primary endpoint. The Moderna vaccine study really had just kind of one primary endpoint, which was prevention of symptomatic COVID-19 at least 14 days after vaccination. And this is an interesting point here, is that when people start to think about, hey, when should I have full protection from the vaccine? For the Moderna, based on this data, they're reporting 14 days after vaccination, and that's the second dose, and Pfizer 7 days. So based on the data, you can really say, hey, after 7 days from your second Pfizer vaccine is when you should be able to say that you are as likely to be protected as any other time, whereas for the Moderna, probably 14 days. Secondary endpoints were severe COVID-19 infection in both study groups, and that just, if you read the studies, the definition of severe is pretty similar between the two. It has things to do with, hospitalization, heart rate, pulse oximetry, those sorts of things that would likely get you admitted to the hospital. So who is eligible for vaccination right now? So based on Centers for Disease Control, I put the website there for you. As of 22 December 2020, anyone in phase 1A, 1B, or 1C should be able to receive the vaccine, with priority continued to be given to patients in the 1A category. So 1A is healthcare workers and long-term care facility residents. Phase 1B is frontline essential workers and people age 75 or older. Phase 1C is age 65 to 74 or age 16 to 64 with underlying medical conditions. So that, I think, is important, because I think based on 1C, a lot of patients that we take care of with GYN cancers would certainly fall into the 1B or 1C category. I think cancer would be considered a significant underlying medical condition that if you're not over the age of 75, you could get in with this 1C designation. If you feel like you meet criteria for phase 1C and you need a physician's note to confirm your underlying medical condition, please contact your doctor. So where do I get the vaccine? That's a question I get every day at work. How do I get it? This is just a list of suggestions, so you can talk with your primary care provider, local retail pharmacies like Walgreens, CVS, Walmart, HEB. Just need to call and check availability. There's news coming out every week about vaccines going to be shipped to retail pharmacies as a way to increase the distribution. So I would keep a close eye on what your local retail pharmacies have available. The Veterans Affairs Hospital and clinics, again, only for eligible beneficiaries, but you can look at the website I've got there. Should cover the South Texas area here. The local military health system for TRICARE beneficiaries. Again, for San Antonio area updates and appointment booking, you can go to the website I have listed there. It doesn't look to me currently that they are booking anyone, but I've heard that is forthcoming, although I don't have a timeline on that. You can also look at local city and county health departments, San Antonio, Bexar, Comal, etc. The city of San Antonio has the Alamo Dome appointment info booking. The website is listed there. So the big question that we all have to answer too is the COVID-19 vaccination for me? I think things to consider. Number one is safety. So immediate adverse effects. So the only definitively available data we have is for people that were included in those trials that I talked about on the second slide or third slide. So the Moderna and the Pfizer vaccine trials. As I pointed out, neither one of those trials had any real substantial number of patients with cancer. So if you've got cancer or you're in remission or you're a cancer survivor, I don't we don't know if there are any immediate adverse effects for you that would be different from anybody else that was included in those trials. For long-term adverse effects, we don't know that for anybody. We need more data. All we have right now is a few months worth of data. So the other big piece is to consider efficacy, right? So is what we call immunogenicity, meaning when you get the vaccine, do you become immune to the disease? And based on the study report, 95. If you get a Pfizer vaccine, 95% of patients develop enough immunogenicity to prevent symptomatic COVID-19 infection. But again, cancer patients on anti-cancer therapy were not really included in any significant numbers in either of these trials. So questions that you need to ask yourself is my immune system compromised? Is there an ideal time during my chemo cycle to get a vaccine like this? How long does it take for immunity? Remember, we talked about the Pfizer vaccine. Our thoughts are that within 7 days after that second dose, you should be sufficiently immune, whereas Moderna, it might be more like 14 days. What are the goals of my cancer therapy, and should I take a break from therapy to optimize the vaccine efficacy? For patients that have cancer but are off therapy or they're undergoing surveillance, again, the big question there is my immune system compromised for any reason? And for cancer survivors who are, they've kind of graduated from surveillance, and the same question, is my immune system compromised for any reason? Those are probably the most likely things that would impact vaccine efficacy. More on efficacy here. So there's no clear data specific to COVID-19 vaccines in patients with active cancer. So what might we do to glean some information here? So we can use historical data and other vaccines as a clue. For example, there is some evidence of decreased immunogenicity to influenza, pneumonia, shingles vaccine, and immunocompromised patients. So who are immunocompromised patients? Well, people that have received solid organ transplants like kidneys, livers, hearts, and things like that, are always on chronic immune suppression to prevent their body from rejecting that transplanted organ, and therefore the immune system is not in an optimal condition. Patients that have rheumatologic conditions where your own body's immune system is attacking itself, causing inflammation and a host of problems. In patients on some cancer therapies, perhaps. So any of these conditions, you could be on medications that are impacting your body's immune system. And we've got some data from other vaccines to show that patients in these categories may not develop the same immune response to the vaccines. So there have been proposed strategies to enhance immunogenicity in immunocompromised patients, and those could include giving higher doses of the vaccines when people actually get them. Maybe they need a more frequent dose schedule, and maybe we need to optimize the timing of the vaccine to be given during a break from immunosuppressive drug therapy. So what do the experts say? So the American Society of Clinical Oncology, which is known as ASCO, I've got a website for you there. I mean, really their concluding statement is that patients with cancer and those undergoing active anti-cancer therapy can be offered COVID-19 vaccine as long as there's no component of vaccine that is contraindicated in conjunction with the current drug regimen, and so long as the patient is aware that we have a lack of safety and efficacy data for patients with cancer. The National Comprehensive Cancer Network, so the NCCN website listed there, they have a nice document that they've drafted with support from quite a few experts in the fields of cancer care and infectious disease. And you can see from this table that they break it down into patients with different kinds of cancer and perhaps the kind of treatment you're receiving. Really, for patients with GYN cancers, you're going to fall into this section down here, the solid tumor malignancies, and timing of the vaccine. The COVID vaccine is listed here whenever the vaccine is available. So this group of panel of experts is not recommending any delay. They're recommending that as soon as you can get the vaccine, you should get it. So some conclusions on what we've discussed here for the COVID-19 vaccine. There's really limited data about safety and efficacy. There is the possibility of decreased immunogenicity, just meaning the effectiveness of the vaccine for patients on cancer therapy, although we just don't have any clear data to confirm or deny that. But we can, again, like we talked about, look at immunogenicity or vaccine effectiveness in other situations of immunocompromise and see that it could be plausible. I think this is an individualized decision, really need to depend on current disease status and treatment regimens, and something you should discuss with your provider if you are uncertain. Keep in mind here that there's plenty of support to get the vaccine from ASCO and the NCCN. Just as long as you go into it with your eyes wide open, knowing there's we have limited data, and that unless it's clearly contraindicated, it's probably reasonable to pursue. And again, clearly contraindicated would be, there are some clear contraindications as specified by the vaccine makers, and they would ask you that before you actually get the vaccine, just like when you go to get a flu shot, they ask if you've got an egg allergy, that sort of thing. And then if there's a component of the vaccine itself that would negatively interact with any currently, any current anti-cancer therapy that a person might be on. So I hope that was a little helpful review of the COVID-19 vaccination. And we're going to switch gears now and start talking about gynecologic cancer recurrence. So I just want to point out, I'm trying to think big picture here, understanding that remission precedes surveillance. So following all primary therapy, which would include surgery, chemotherapy, radiation, or some combination thereof, you should be assessed for response to therapy. So how do we assess for response to therapy? We do things like imaging, we meet with you, we review symptoms of concern, we do a physical exam, we get some lab work, some blood work, and look at tumor markers. And then after all these assessments, then we usually are able to make a categorization and say, yes, you appear to be in remission, or we think you have active or persistent disease. So if you fall into the remission category and we think you're in remission, then you begin a period of surveillance. And I wrote here, surveillance precedes recurrence. So there are well-defined surveillance guidelines put forth by several professional organizations, most prominently the National Comprehensive Cancer Network, NCCN, and then our own Society of Gynecologic Oncologists, the SGO. So these professional guidelines really recommend components and frequency of surveillance evaluation, and they're really dictated by the tumor site. So whether it's a cervix, uterus, ovary, it's also dictated by the stage of disease at diagnosis, treatment-specific factors as well. Typically during surveillance, we're going to be looking at a physical exam, some kind of lab work, and review of symptoms. So, those are kind of the bare minimum. The question about imaging, which everybody always wants to know. I mean, everybody wants to have a CT scan every 3 months, but really, it's not cost effective, meaning that's not the best way to detect recurrence typically, and it's very expensive, and it's going to expose somebody to radiation. And so because of that reason, imaging is rarely a routine part of surveillance, and it's typically only obtained or sought based on some other concerning findings. So during the exam, the surveillance exam, something is found, or on the lab work, something is not right, or tumor markers are rising, or you have some concerning symptoms. So why do we do surveillance? Well, three reasons, at least 3 reasons I can think of. So we're going to look to detect any new or secondary treatment-related cancers. So that's, unfortunately, some of the, to cure cancer, we treat patients with some pretty radical therapies like chemotherapy and radiation, and unfortunately, one of the risks of those treatments is that they can actually cause a new cancer that's totally unrelated to the cancer we're treating you for. So we're always on the lookout for that. The second reason we do surveillance is to detect and manage treatment-related complications. Third reason is to detect recurrence of the cancer we just treated. And so a great question that I know many patients with cancer have, or who are in remission have, is, well, how do I know if I have a cancer recurrence? And sometimes it's obvious because it's what we call a symptomatic recurrence, meaning you've got some worrisome symptoms that correlate with active disease. But oftentimes it's asymptomatic, meaning there may be recurrence, there may be active disease going on, but you don't feel sick, and we don't know that you have it. And the way that we usually pick that up is either there's some sort of exam finding, or we see some lab tests, some rising tumor markers, or perhaps we did get some imaging and we see something concerning on the imaging. So what are the main symptoms of recurrence? So unexpected weight loss, vaginal bleeding, rectal bleeding, blood in the urine, persistent cough or shortness of breath, persistent abdominal bloating, nausea, vomiting, pain, constipation, asymmetric swelling in an extremity. This could be from an enlarged lymph node that's blocking blood egress from the leg or an arm or somewhere. A new mass, lump, or growth at any location. New skin bruising or rash. Persistent headache, vision changes, loss of coordination or dexterity. This is certainly not an exhaustive list, but if any of these things are going on, it would be worth being seen by your doctor sooner than later. Again, let's get into a little bit more about this concept of asymptomatic versus symptomatic recurrences. So one thing to keep in mind is that all recurrences become symptomatic eventually. And that should be kind of common sense, right? So factors that determine how long it takes to develop symptoms include the location of the recurrence, the duration of the existence of that recurrence, so how long has the recurrence been present, and then how fast is the recurrent disease growing. So not all cancers or recurrences are going to grow and spread at the same rate. So prognosis and treatment options are often the same. So that's probably one of the most important points to make here in this whole talk about cancer recurrence. So although it would make intuitive sense to think that the earlier I diagnose a recurrence, the better the outcome, it unfortunately doesn't tend to always play out that way. So it may mean that detecting a recurrence earlier could mean that you are on treatment longer, but it doesn't always change the ultimate outcome. Meaning it doesn't mean that we can all of a sudden cure this most of the time. So an asymptomatic recurrence, if you have that and it's detected, you may have the luxury of time to decide what treatment to do and when to start it. whereas a symptomatic recurrence, they usually have to begin treatment immediately. And then the other important thing to ask is, if you've got a recurrence, what's the goal of treatment for these recurrences? And when we as doctors think about treating a patient for cancer, we always have to think of the overarching goal of that treatment. And usually there's two treatment pathways, or two goals of treatment. One is curative and the other is palliative. So when a patient is diagnosed with recurrent cancer, it's more often than not the goals of treatment are palliative, meaning to treat symptoms, rather than curative, unfortunately. So the last slide here is really just a slide on prevention of cancer recurrence. So things that we can do to prevent a cancer recurrence once you're in remission. Sometimes there's maintenance therapies available, so you can talk to your oncologist to see if you qualify. There's not always a maintenance therapy available, but if there is, you want to make sure that you are a candidate for that. And again, it's not every patient is a candidate for maintenance therapy when they exist. So key questions to ask too are, if you are a candidate, is, well, what are the benefits compared to the side effects? Because usually these therapies do have toxicities, and you want to make sure that you keep quality of life as a priority, and as you think about what to do going forward. So other things you may be able to do to prevent cancer recurrence, and again, I point out non-medical therapies. I point out that in a lot of cases rigorous scientific data might be lacking here, but I do think anyone that's been diagnosed with cancer has probably read books on diet and exercise and psychology and things like that as a way to try to prevent recurrence and to treat cancer. And so I think there is potentially some truth to some of these things, and I think they're all worth considering and exploring. And so I put some ideas here. So related to your mind, I think removing stress and anxiety is hugely important. There's definitely been data and research done in animals that increased stress releases hormones that are not good for the cancer environment. And so, removing stress and anxiety is very important. Being engaged and staying mentally challenged and sharp, building healthy relationships, all incredibly important, right? From the body standpoint, thinking about exercise, weight loss, dietary changes, set new goals for yourself, push your limits, stop smoking, get control of diabetes and other chronic medical problems. Sometimes things like massage and acupuncture. And then the soul, some people are involved in religious or spiritual practices like prayer and meditation and fellowship and serving others. I think all of these things can work collectively to give you a purpose in life, a purpose beyond just being a cancer patient, and that'll hopefully help take your mind off of some of the stress and concern about possibility of the cancer coming back. So I hope that today we were able to learn some new things. I hope that this was helpful. We're going to flip over to a Zoom discussion here so we can get together collectively via the digital platform and discuss and try to answer any questions anybody has. Thank you.